Britt-Marie Jung. For the past 14 years, I have been learning and teaching thin needle aspiration biopsy. I have come to believe that aspiration and smearing techniques are fundamental for success. This is because it's so much easier to make a diagnosis when there is abundant and well-prepared material. Over the years, I have taught a number of people one-to-one. This works very well, but it takes a lot of time. I have also given a number of lectures, and I have found out that this does not work very well. I have yet to meet a single person who really learned how to perform either aspiration or smearing technique from just listening to a lecture, mine or anybody else's. Therefore, I decided to make this video. I hope this will be an effective tool for you to learn both the basics and the little tricks of the trade. This tape is meant to be played over and over again so that you can study all the little details and come back and review it as you gain experience. You will notice that for the most part, I am not using gloves in this video. This is because there is no real blood present, and also because of technical reasons. This video is divided into several sections. First, I will describe the equipment. This will be followed on several sections on aspiration technique. After that, we will look at smearing, and this will include how to smear excessively bloody material. The last part of the tape deals with how to approach specific sites. This includes the thyroid, masses deep in the neck, and also the axilla, including other spots. Now, let's get started. The equipment is simple, inexpensive, and easily available. There are many types of needles available, some especially designed for thin needle aspiration biopsy. It is my experience that for most purposes, regular beveled hypodermic needles work very well. The range of size is generally 22 to 25 gauge. 23 gauge is my personal favorite and the needle I usually start with. Sometimes I choose a different gauge needle for specific reasons. For instance, if the 23 gauge needle meets great rubbery fibrous resistance in the tissue that makes it difficult to effectively move the needle tip through the tissue, I will switch to a 25 gauge needle. The thinner needle will move more easily and sample more areas in the tissue and therefore collect more cells. On the other hand, if the target has minimal amounts of stroma, like a lymphoma or a melanoma, a thicker 22 gauge needle would collect more material. In addition to the gauge of the needle, I need to choose the length. A short needle is easier to manipulate and does not bend as easily as a long one. Therefore, I will choose a needle that is just long enough to reach the target comfortably. Needles ranging from 5/8 of an inch to 1.5 inches are sufficient for most palpable targets. Longer needles are available for deep-seated targets. The needle should be connected tightly to the disposable syringe. I recommend a slip-top syringe because it is easy to handle and in my experience provides a good seal. The luer lock syringe may provide an even tighter seal, but disconnecting the needle is time-consuming and sometimes difficult. A syringe holder makes the procedure easier to perform by allowing a comfortable one-handed grip of the instrument, leaving the other hand free to stabilize the target. The holders come in different models and for different size syringes. Pick a holder that holds the syringe securely and that is comfortable to operate through the whole procedure. In general, a short distance between hand and target makes the procedure easier. Therefore, a smaller, shorter 10 rather than 20 milliliter syringe and holder are preferable. One might argue that a larger 20 milliliter syringe would be more effective because more suction can be applied. However, in my experience, a small amount of suction is sufficient, about 1 to 3 milliliters. Increasing the amount of suction does not appear to improve the harvest. The one advantage of a larger syringe is the greater capacity when emptying a large cystic space. A way of getting around this with a smaller syringe is simply to disconnect the filled syringe from the needle still placed in the lesion and replace it with an empty one. This maneuver is made easier if you have two guns available. In addition to the biopsy instrument, I need glass slides with one frosted end that can be labeled with a pencil. The smears may either be air-dried for Romanowsky-type stains, such as May Grünwald Giemsa, or alcohol-fixed for Papa-Nicolau, or hematoxylin and eosin. For those slides that need to be fixed in alcohol, I have a jar. A Copland jar with its designed ridges will keep the slides nicely separated. If this is not available, I can use a plain jar and keep the slides apart by applying a paper clip to every other slide. Instead of immersing the slides in alcohol for fixation, I can use spray fixative. The advantage of spray fixation is that fewer cells will be lost compared to immersing. If I am by myself, by the time I have made the smear, placed the slide on the table, picked up the can, positioned it at the right angle and distance, and sprayed the smear, it will most likely be dry. It is crucial that the slides are sprayed immediately after smearing in order to avoid air drying artifact. This is best accomplished by having an assistant ready in position to spray the slides. In order to protect myself, I need a pair of well-fitting disposable gloves. It is not necessary to use sterile gloves for superficial targets. An alcohol swab is sufficient for cleaning the skin when sampling superficial lesions. A gauze pad is used to apply firm pressure after the sampling in order to prevent bruising. A Band-Aid will protect clothing from blood. A vacutainer tube is handy for extracting trapped material from the hub of the needle. I will show this technique later. Toluidine blue stain in a simple drop bottle can be used as a fast stain to assess the material before the patient is released. Application of this stain will be shown later. Air-dried slides can be stored and transported in plastic slide holders. If the slides are put in wet, there will be artifact from prolonged drying time. This artifact will appear even if the lid is left open. Just make sure the smears are completely dry before putting them in. The last item, but certainly not the least important one, is the requisition slip. It has space for all the usual information about the patient and the referring physician. In addition, there are pre-made drawings of various anatomic sites. Here, detailed information about the size, site, and clinical characteristics of the target can be indicated. There is also a space to record the consistency of the target when sampled and the nature of the harvest For example, if it was cystic, necrotic, or exceedingly bloody. Local anesthesia is optional. If you wish to use it, apply buffered anesthetic with a small gauge needle. Suppliers for dentists have low-cost equipment available with needles as thin as 30 gauge. Before demonstrating how to perform a thin needle aspiration biopsy, I'm going to spend a few moments discussing the basic concepts. The name of the technique, thin needle aspiration biopsy, may give the impression that it is possible to simply place the needle and suck out the sample. This will work only if the contents of the mass is liquid. With suction alone in solid targets, they will usually only be scant and often non-diagnostic material. Most masses are made up of islands of epithelial cells set in stromal tissue. The epithelial islands are represented by dark dots and the stroma by light background. In general, the most important information is in the epithelial islands. In order to extract sufficient amounts of material, it is necessary to move the needle back and forth through the tissue. The tip of the needle will then dislodge small fragments of tissue. These fragments will collect inside the needle. Applying suction helps in collecting and transporting tissue fragments up through the needle. If the target is not completely fixed to the surrounding tissues, it will likely move back and forth with the needle, preventing effective sampling. Therefore, it is important in cases of palpable targets to hold them down firmly. In larger targets, 3 centimeters and up, this can usually be easily done by using the thumb and opposing fingers. However, in smaller targets, it is more effective to use the forefinger and middle finger. Note how close the fingers are to the nodule in order to keep it firmly in place. Often, it helps to initially place the fingers together on top of the mass and then stretch the skin by spreading the fingers. Specific pointers for how to immobilize and approach difficult and unusual targets will follow in a special section. Now it is time to start the thin needle aspiration biopsy. The first step is careful palpation of the target. Ask yourself how large the mass is and how deep under the skin it is situated. Also, consider if there are any structures nearby that you would like to avoid. Such structures may be major blood vessels, the trachea, or bony parts. Based on this information, plan for the angle of the needle and the depth of penetration in order to get in optimal position. Most targets can be approached at a 90-degree angle, but in most cases it is more comfortable and practical to use a 45 to 30-degree angle. When using the 90-degree approach, the needle should penetrate the skin right on top of the nodule. If the same entry point is used with a 45-degree angle, the needle will in most cases not enter the target. Instead, one has to compensate for the more acute angle by penetrating the skin adjacent to the mass. Failure to place the needle correctly is one of the most common causes of poor yield. Next, I will position the patient and myself for the procedure. The goal is a good specimen, and that, in my experience, is easiest to achieve if both I and the patient are in a comfortable position. More than one position may be considered before going ahead. For instance, in this patient with a submental node, I can either position my hand like this and aim the needle in this direction, or change my approach this way. Most people have a slight hand tremor. This may interfere with the exact needle placement, especially in small targets. Potential problems may be avoided by stabilizing the instrument, and this can be achieved in several ways. One possibility is to lean the barrel of the syringe against the forefinger of the palpating hand. Make sure not to use the needle for support, since this will cause contamination. In order to get a good angle for sampling, it is necessary to bend the fore and middle finger in this fashion, as opposed to keeping them flat on the patient's skin. Using the thumb like this is another way of stabilizing the instrument. Once the needle has been placed in the target, the support is not necessary anymore and can be withdrawn. Both these positions may feel awkward at first, but with some practice they will be very helpful. We are now in position and ready to place the needle for sampling. In order to spare our patient, I am going to do a slow, step-by-step demonstration of the biopsy technique using liver purchased at the grocer, packaged in 2 layers of latex gloves. This is an excellent tool for practicing both thin needle aspiration biopsy technique and smearing. Tumors received fresh in surgical pathology can also be used. I have indicated the size and location of our imagined target within the liver with a mark on the surface. In this case, the imagined target is 1 centimeter in diameter and located 1/2 centimeter under the surface. I am palpating the target, placing my fingers on top of it, and then spreading apart, stretching the skin and staying close to the target for additional control, making sure the target will stay put throughout the whole procedure.